My name is Michel Vaillant from Physio-Control, which is a Stryker medical company, and today really talking about benefits and advantage, especially for the patient, but also for the caregivers when using mechanical chest compression, and most specifically the LUCAS mechanical CPR. There are a few things that are already known, and I will not spend too much time on that, with regards to improving resuscitation. First one, and one of the most significant one that was specified in the Guidelines 2000 from the American Heart Association, is that minimizing CPR interruption will increase survival. So as long or the least interruption in cardiopulmonary resuscitation there is, ideally no longer than 10 seconds, you can really see an increase in survival. Also, increasing the number of individuals that are trained in CPR and in the use of an automated external defibrillator will also increase survival in the community. One thing that is known as well is that for every minute that there is delay from sudden cardiac arrest until you have CPR started and defibrillation, you'll lose between 10 and 12% chances of survival. The use of application as well to locate AEDs and rescuer to link them with victims also show some promises, and mechanical CPR in certain circumstances can improve survival also. But naturally, what about LUCAS and mechanical CPR? So let's look at a few advantages, the improvements that have been made over the years, and the connectivity about that. So LUCAS mechanical CPR has been commercialized over the last 12 years around the world. More than 16,000 devices have been deployed and remains the market leader. We also have more than 200 publications, including the largest clinical study, which is the LINK trial, that has been conducted over a 5-year period in 6 or 7 major centers around the world, and that have proven that LUCAS CPR is as good as high-quality CPR, high-quality manual CPR. And what does high-quality manual CPR means is that all the crews, the people that were involved in the study, were trained twice per year for 1 day in cardiopulmonary resuscitation for manual CPR, which means that if we look at most hospitals around the world, if people get trained or retrained in CPR every 2 or 3 years, that's good. So in that study, they were trained twice per year, and that's against what we compared the LUCAS mechanical CPR. LUCAS is also appreciated and trusted, endorsed by many users as being easy to use and can be fitted onto a patient within 7 seconds, which means that we also, when we look at the guidelines, which says we should not have any interruptions of more than 10 seconds, well, you can reach that with LUCAS. And once the device is applied onto the patient, it's very safe and it will conduct CPR according to the guideline. So at more than 100 compressions per minute, which is 102, at 5.3 centimeter depth, so between 5 and 6 centimeter, and it will do it according to either the ratio of 30 compressions to ventilation or continuous compression if the patient is intubated. Proven safe and efficient, both for the users and also for the patient, with over 99% good neurological outcome when LUCAS is being used during CPR. And it provides as well consistent high-quality CPR. Proven also to perform reliably in more than 99% of documented studies with regards to its operational reliability. And it's also compatible for use in cath lab, which means that in many cath labs around the world, If cardiac arrest occurred during the PCI procedure, then they will install the LUCAS and continue the procedure while LUCAS is on giving mechanical CPR. Some of the advantages are the suction cup, which also does effective compression and decompression of the chest. And naturally, the device is also easy to install, quick, and easy to use. So this is how the device looks, the suction cup and the installation, with also for the cath lab a fully radio translucent backplate. Okay, so the backplate here that you see goes underneath the patient, and the device that you saw goes completely over the patient, ensuring constant quality mechanical CPR. Okay, and here you have some idea on how and the view you can have when LUCAS is being used in a PCI and a cath lab for PCI procedure, as to what you are able to see when the procedure is being given, depending on the solution you're using. The interface is very easy to use, as it allows you to do 30 compressions for 2 ventilation. It will automatically stop after 30 compression, allowing you to give 2 ventilations, or it will alert you to give ventilation every 10 seconds, or every 10 compressions, sorry, when it's on continuous mode. The device also self-adjusts on the chest in order to make sure that there is the right application or the right force being given, and that it prevents trauma as well on the patient. Naturally, any device, whether it's LUCAS or any other mechanical CPR device, good training and during the in-service, naturally, and regular retraining of the team will ensure that it will be applied correctly, that it will work correctly, and that it will also be applied in a very short time frame, in order to make sure that there's never any CPR interruption of more than 10 seconds. Some of the new advantages as well on the new LUCAS3 CPR machine is the fact that it now records data, and it's able to transmit it as well. So data you will be getting out of the device will be what chest compression ratio did the patient get, okay, with the LUCAS CPR device, what was the longest pause or stop into compression, and if there were any alarms or any issue that happened during the procedure. The LUCAS will collect data with regards to the compression, the count and duration, any pauses that happen, user interaction on-off, readjust the device, any alert that would have happened, and also will inform you about battery status. Nevertheless, you also have AC or DC power that can be used with the device for continuous operation. And this data can be retrieved onto a computer and used for analysis. And you can get different reports that are being generated, which give you certain views. And these reports are very, very important, especially when you use debriefing following a cardiac arrest, because these reports will help you conduct your debriefing and increase the follow-up and the improvement into the use of the device.
1 minute,
What
please.
do customer value about the LUCAS is, or the report that are being given, is the possibility to learn and improve from each code by reviewing when interruptions were made, why pauses were made, and what happened in altering that. And to confirm and also document the chest compression quality. So in review, and in light of the previous presentation, so the LUCAS is easy to carry, can be used both into pre-hospital setting or hospital setting, and it's comfortable to use, not necessarily for the patient who gets it on the chest, but mostly for the user. And you also know that doing cardiopulmonary resuscitation, manual cardiopulmonary resuscitation, is quite exhausting. So naturally, LUCAS will get this done with minimal interruption. It's cath lab compatible, easy to use, easy to clean, and also easy to carry. Thank you.
Thank you.
Thank you.
A few questions or a comment. Number one, you said that it is endorsed by users. I thought the first thing that companies come and say this machine or that device is endorsed by FDA or some regulatory bodies, but I thought that you said endorsed by users only.
No, it's endorsed by user. Naturally, the device, in order to be commercialized, has 510K and PMA approval from FDA. Okay. So the device is certified. We also have CE mark. It's also RCTA DO 160, so approved for flight. It has flight certification. But what I mean is that we have, with the 16,000 devices that have been deployed worldwide during the past 12 years, we have endorsement also from user who mainly tell us and others as well that it's easy to use, it gives performance, it helps them improve the management of the cardiac arrest, and it also helps them save more lives. So that's what I meant.
Number two, you mentioned that there is a 99% good neurological recovery. That's good to be true. That's good to be true in terms of what we see actually. So if that's the case, then nobody should do manual CPR. It should be all your machine, basically. Okay. Because what we see in real practical life, that you should probably get about 10% of your patient will survive a code, mm-hmm. and then most of these patients end up on machines, okay. and the ICU, most of them will die. Okay. You have a very small percentage of people who will survive, with very few people who will benefit okay. from your CPR to start with. Okay. 99%, I think it's way too many okay. and too exaggerating.
Okay. When we talk about 99% good outcome is when there is patient survival and when LUCAS has been used as the initial way of doing CPR. So meaning there is a cardiac arrest, LUCAS is used immediately and the patient recovers. In 99%, the score for neurological outcome is either a 1 or a 2 in 99% of the cases. When LUCAS has been used as the initial and there is survival. So naturally, it's true that you cannot save every patient. I agree with you on that matter. I'm not saying that LUCAS is saving 99% of the patient, but those who are saved, and when LUCAS was the first intention and the first technology to use as CPR, those who survive have good neurological outcome in 99% of the cases.
I'm very interested to implement this in our practice and see what's the outcome. I doubt it.
The documentation is there. I'm not just saying it. The documentation is there from the different reports that have been done, clinical trials, randomized trials with peer review. So
one last comment. Again, this is nothing from your side, but what I have noticed and wherever I worked with this machine being available, that whoever was responsible for the patient used to hook patients on this machine and move on to deal with other patients. So the patient who's in a cardiac arrest situation, because of this machine is pumping onto the chest, nobody's around the patient. So again, I see your point where cardiac arrest is an exhausting process by itself. It needs manpower or woman power to do CPR and so on. So the machine does this, but it also gives some people leeway of leaving the patient go and do something else.
No,
And
no,
again,
it's
I'm
not
not saying
that.
that. Again, this is not with you.
No.
That's my observation with this machine being in use.
No. By having mechanical CPR and by having that uninterrupted CPR and good quality, it allows better management of the team during the cardiac arrest because you don't have someone standing over the patient, and it's much easier to move around, much more easier as well for the doctor who's in charge of the cardiac arrest to assign task to everyone and to ensure a better management. So it's not, it hasn't been made so that you can go and take a coffee while you're, while Lucas is on.
So, but the reality is different than what you are telling.
Yeah, thank you. No problem. I don't have any issue, as you can see.
Yeah. Good morning, everybody.
Good morning.
So, first of all, I'm Casualty Mubarak Hospital matron or ADN. I will give you just our feedback from using your machine on our casualty. The one we have is the old generation, I believe. We don't have the option on the modes that you can adjust every 30 minutes. The one we have will give continuous pressure. Our experiences during the crisis of bronchial asthma, the one we had on Thursday, that was 10 days back almost, we got a patient who's gone into cardiac arrest. They have been resuscitated using your machine, the old generation again, but it's the same concept. Honestly, what is practical that you can start and initiate the compression through the machine so fast, that one I agree. Within 7 seconds, honestly, you will have it in and you will start the compression through, which is more practical for us on the recess. But the feedback of getting the patient survive with the neurological recovery again, as Dr. Adel described, that was another issue. Because we had 3 patients who has been arrested, who has been resuscitated. And they reached the ICU, but all of them passed away. We did not get any patient back. They were alive, but for neurologically they got into severe hypoxia and we lost them all. It was a matter of time, even though for a while we thought that they have been resuscitated. So the outcome is still a question, but practical-wise, it's honestly so easy to be started the compression through, and that one is very practical on the resus on casualty, but still the outcome, this is something I believe we need to look more closer on, and this is our experience, and recently, you know, within only 2 weeks. Thank you.
Okay, thank you.
The outcome of any resuscitation depends on many things. Yes, it's not about only when you are doing the CPR. It's the primary disease of the patient, how you are giving it's not only the chest compression. The machine is giving the compressions, not giving the drugs, not giving the DC, not giving the nebulization, not doing the intubation fast or something else. Yani, that's what I think.